everybody. My name is Ante. I'm a third-year medical student, and I would just like to talk to you before we begin here why we're doing this and why we chose to present this case today. So Theja and I started our pediatric rotation a month ago, and within the first week, my attending physician, Dr. Graham, sent me in to see two twins and told me that what I'm about to see in the file that he was going to show me is something that he has never seen in his practice during his 30 years as a physician. And he said, interestingly enough, that this is the second time this year, within the last 6 months, that he has seen this pathology. So this was of great interest to us, and we wanted to see the patient and wanted to examine what happened, and this is how this presentation came to be. So I'll let Theja.
To present with an aortic coarctation. And there's two etiologies because the theories behind both of these aren't necessarily outlined very well in the literature, but these are the two most prominent theories. And the first is decrease of blood flow anterograde in the uterus that prevents proper formation of the aorta. And the most at-risk area is distal to the isthmus near the left subclavian artery, where all the branches branch out, and it's the area with the least amount of oxygenation, which would imply decreased formation of the vasculature. Now, the second theory that's been the most common one, in my opinion, is that there's abnormal migration of ductal tissue into the aortic wall. Now, the migration of this tissue can happen for numerous reasons, and anyone's guess is as good as mine because it's honestly an idiopathic process. And as I go on to the next slide, we'll talk about why aortic pathology, in particular, things like Turner syndrome and left ventricular outflow obstruction are of interest because unlike other congenital heart defects, coarctation of the aorta does not present in isolation very commonly. It presents in the grander context, with the most common being Turner syndrome. Now, Turner syndrome and left ventricular outflow obstruction have been studied quite heavily, and there is a good fund of knowledge for those diseases. However, the third issue here is unspecified inflammatory diseases of the aorta. Now, this is a broad encompassing term which includes inflammatory vasculitis such as Wegener's, and it also includes things like a viral myocarditis. And these things, the pathology behind them is, like I said, it's unspecified because you would assume that intimal hyperplasia is responding to chronic insults in utero and necessarily throughout the first few days of life, and that in turn causes increased tissue development in the aorta, resulting in the final stenosis. On the next slide, I'll just briefly talk about our introduction to the case. I'll talk briefly about just the presentation during birth, and I'll let Ante talk more about what actually happened during the physical examination. But with an uncomplicated prenatal course, JH, our patient, was delivered as part of a dizygotic twin pregnancy at 37 weeks gestation. On presentation at 1 and 5 minutes, APGAR scores were 8 and 10 respectively, as well as his twin sister was doing well upon her presentation as well. On the next slide, we'll just talk about the routine screening that happens at St. Luke's East, which is where this baby was born. Routine delivery included maternal screening for things such as maternal COVID, HIV, Group B strep, RPR syphilis, and all of those were in fact negative upon the patient's admission to the hospital. Of note, patient received all appropriate newborn prophylaxis, and his actual presentation for things such as maternal viral screenings was undetermined at that initial point. And I'll turn it over to my partner, Ante.
All right, so now we get into the fun part. So our patient, as Theja said, when born, appeared normal, all of his findings were within normal limits. However, every newborn receives a cardiac screen within the first 24 hours. And what cardiac screen consists of is a pulse ox, so pulse oximetry measurements in upper and lower extremities to make sure that both the upper and lower part of the body are getting adequate blood supply. So our patient failed the cardiac screen, which prompted further investigation. Additionally, his femoral pulses, so pulses in his legs, were diminished, and lower extremity cyanosis set in. So this is a immediate red flag to the neonatal care team, as the baby is not getting good perfusion below the level of the heart. So immediate steps take place when a baby presents with this, and the first thing that is usually done is a CT. So a CT of the patient showed, and I'm going to quote here what the radiologist said: a complete disconnection of the aortic arch and descending aorta with a PDA providing most blood flow to the descending aorta. There was also a patent foramina valve. And now let's just break this down, because many of you that are listening here do understand what all this means, but for some of that are maybe first or second year students that haven't gotten into cardiac pathology yet or anatomy might not understand. So complete disconnection, obviously there is interruption of the flow, and the ascending aorta that we see right here is not connected to this descending aorta. All right, so there we're saying that the disconnection happens between the arch and the descending aorta, which means in this area right here, past the left subclavian artery. And then we talk about the PDA, or patent ductus arteriosus. And I'll explain this a little more in the next slide, but essentially what it means, there is a connection between the pulmonary vasculature, or the pulmonary artery, and the descending aorta. In a way, this can provide extra blood flow past this obstruction to the descending aorta. A patent foramina valve is also important to mention because it's a connection between the left and right atria. Now, this will allow, as I explain on the next slide, how our patient is still getting some blood to the lower extremity. So if we look at this picture here, this is a picture of the posterior aspect of the heart. So it might be a little difficult to orient yourself, because, but what we have here, or sorry, the anterior aspect, but it might be difficult to orient as the pulmonary trunk is in front here. So what we have here is the patent ductus arteriosus providing some of the blood, some of the venous blood, or the non-oxygenated blood from the right heart into the descending aorta. And then additionally, if our patient has a patent foramina valve, the connection between the right and left atrium, that blood can now flow from left atrium into right atrium, right ventricle, and into the aorta. So some of the oxygenated blood is still reaching the lower extremities. This was probably also why patient presented a little late with the lower extremity cyanosis. But another thing is this patent ductus arteriosus. So first thing is, when this was seen on the CT, the NICU team started prostaglandins. So what are prostaglandins? Well, they're just medication that will keep this ductus arteriosus open. So we don't, once the usually after 24 hours of birth, the ductus arteriosus will close, and only a remnant will remain throughout adulthood. But in our patient, if that were to happen, because this ductus was providing blood distal to the occlusion, we needed to keep it open. So prostaglandins were administered, and the patient was transferred to the Children's Mercy Hospital immediately. So now let's understand this a little bit more. Once at Children's Mercy, the patient received his first echocardiogram. So this is just an ultrasound of the heart, and this is a good picture here of the patent foramina valve, or the connection between the left atrium and the right atrium. And we can see here how the blood can pass freely from one side to the other. So now if we're thinking, oxygenated blood comes into the left atrium, can go over into the right atrium, goes into the right ventricle, back into the pulmonary vasculature, but passes through that patent ductus arteriosus into the descending aorta. Now, this echo also showed an ovoid echogenic structure in the aortic arch that was consistent with a thrombus. And this is something new. Everybody so far thought that this was your usual run-of-the-mill coarctation of the aorta, but now an echo is showing something very different. We have a almost complete occlusion of the aorta by a thrombus. Now, a neonatal thrombus is a very rare occurrence. 1 in a million of neonates will experience significant thrombotic occlusion. So why is our baby clotting was the next question. Well, here we go to the hematology consult. And on the right here, you can see this is from the Robbins pathology textbook. What are the most common genetic causes of hypercoagulability? And these things include like things such as a factor V Leiden mutation, a prothrombin mutations, and some other more rarer mutations that can occur in neonates. But hematology determined that our baby has a positive blood, mother was O negative, which could cause some RH incompatibility, ABO and RH incompatibilities. But the Coombs test was negative, and Coombs test just tells us that there is nothing from the mom attacking the red blood cells of the infant. All of the other genetic mutations that could be tested for, such as the antiphospholipid syndrome, which would have anticardiolipin and beta-2 glycoprotein antibodies, were negative, such as the factor V Leiden was negative and the prothrombin mutation was negative. So this leaves it up for discussion. Why did our baby clot in the first place? So next we turn to the treatment. And since this was a very urgent case, our patient was declared NPO and TPN, which means that he was to receive nothing by mouth, no fluids or food, which he would only receive breast milk at this age. So he would not receive any breast milk, and all of his nutrition would be received through an IV port. Additionally, a bivalirudin drip was started. So what is bivalirudin? And I want you to look, you who are familiar with this cascade, the cascade will understand that bivalirudin is a direct thrombin inhibitor. But those of you who have not studied this yet, I want you to just look down here. We have a cross-link fibrin clot. So this is our clot formation on the bottom. If bivalirudin stops thrombin, fibrinogen will not be able to convert to fibrin, and we will not get our clot. All right, so I want you to remember this. Fibrin does not go to clot if we don't have thrombin. Okay, so now the question was, well, we are stopping the further clotting, but we need to do something about the current blockade. And this is where the TPA comes in. So tissue plasminogen activator, for those of you who don't know, works in a way of activating plasminogen into plasmin that breaks down the fibrin clot. So if you remember from the previous picture, we had that fibrin clot on the bottom. Now we're going to use plasmin, which will be activated by our drug, to break down this clot. So now we're administering both drugs that will stop further clotting and that will dissolve the already existing thrombus. And this happened on the day of life 4. So then we have all the follow-up echoes. We need to monitor this baby, every day and see how he is improving. So on day of life 5, we noticed that after the administration of the tissue plasminogen activator, the thrombus decreased in size. And I put here 3 by 4 millimeters. Now this might not seem a lot. The 3 by 4 millimeter clot is not that big. But when we talk about neonates, their aortic isthmus, which is the narrowest part of the aorta, can measure anywhere between 0.33 to 1 centimeter. So it can be very small, and thrombus of this size could actually have an impact on the vasculature. And just again, this was after the TPA was administered. This clot was much bigger before. Patient progressed well over the next couple of days, and he, on day of life 7, he resumed breastfeeding. And on day of life 9, there was another echo, which showed now the abscess of the thrombus and normal aortic isthmus measurements. Now, what this means is that thrombus is now completely gone, and this confirms that we did not have a coarctation of the aorta, as the isthmus has normal measurements. Patient was kept in the hospital for a couple more days to make sure that everything was going well. And on day of life 11, he had another echo that now confirmed the abscess of the thrombus. At this point, we have a baby that seems healthy. He's doing well. He's gaining weight and seems to be ready to go home. So now what do we need to do for him before he goes home, and how are we going to manage this? Well, we're still not sure of why he clotted. And we still don't know could he clot again, and if there were any other problems or clots elsewhere in the body. So discharge was planned, and patient was put on daily baby aspirin. Now this posed question of possible Ray's syndrome, and usually we discourage use of aspirin in all children under the age of 18 due to Ray's syndrome. And all Ray's syndrome is liver failure that can cause significant cerebral edema and ultimately death of a patient or significant pathology that would require liver transplant. This usually happens in a viral infection, but in this instance, our patient we did not have a diagnosis in place to tell us why the clotting was happening. So we had to take all the precautions, and the patient had to have some kind of anticoagulative drug, and aspirin being one of the least dangerous anti-clotting drugs was chosen for this. Patient was also scheduled for a 5th echo to be done at the end of September, end of this month, at the Children's Mercy Hospital, and he was also to be seen at our practice with our attending physician at 2 weeks and 1 month of age. So I had the privilege of seeing these babies, both our patient and his twin sister, on 2 weeks and 1 month. And really, here there was not much to be seen. Both were developing well. Both were growing, gaining weight appropriately. Both were on breast milk, and there was no concerns or complaints from the parents. So here, to not go into everything, I just included this picture because they're very cute twins, and they were doing amazing. So now we need to ask ourselves, well, what could have this all been caused by? And I'm going to let Theja take over for that.
Thank you. So on the slide, I'm going to sort of just reiterate why this case was important. Ante touched on it briefly, but we have this neonate presenting JH. He presented with a rare aortic thrombus in the setting of a suspected aortic isthmus without any risk factors and no genetic predisposition. More so, our attendee noticed that this was the first instance of pathology that he's ever seen in his career, and that there was a similar one that occurred a few months earlier. So, this raises the question, a rhetorical question, what has been going on in the past few months that has been known to be classified as a disease of hypercoagulability? And why is it causing this pathology in neonates? And the buzzword we're looking for is COVID-19. COVID-19 was initially described as a disease solely of the respiratory syndrome. And then more recent literature has diverged that it has actually been shown to be a disease of vascular pathology, in particular, one of hypercoagulability. And there is limited literature on this, and even more limited literature on this regarding neonates and the maternal course. Now, we have an infant who has no disposition or receptor for hypercoagulability, but we do know that the role of pregnancy is a hypercoagulable state. In the diagram, you can see in the top right that pregnancy is needed to, maintain minimal turbulence of the blood as well as minimize hemorrhage. It's a physiologic response to make sure that mom doesn't bleed out during birth. So it's a hypercoagulable state combined with, the suspect of COVID. Now, as mentioned earlier, the COVID screen on mom was negative. It was a defined negative viral PCR test, but father who was in the room was not tested, as well as certain regulations about the transport of JH just between the hospital rooms, the risk of nosocomial infection with COVID. Those are all things that we have to consider when wondering why he presented so uniquely and so rarely. And so on the next slide, I'll talk about the really interesting part was why this was initially considered a coarctation rather than a thrombus. And the simple answer that you can say is that we never knew, or that the CT was misread. It was just a bad radiology. But I think that would be oversimplifying. JH presented in the near prototypical manner of a coarctation. He had lower extremity cyanosis with diminished bilateral femoral pulses. That would just be a textbook definition of a suspected coarctation, and especially with coarctation being so much more common than any sort of 1 in a million aortic thrombus. And Ante did touch on it, that with the normal isthmic measurements on the third CT, that there actually was no coarctation, and that it was the thrombus that masked itself as the coarctation. And this brings us to our sort of final conclusion on what we learned from this case. We have a neonate who's presenting with a relatively serious pathology, a relatively life-altering pathology. And if it wasn't for the key factor of the PFO and the PDA, the holes in the heart that are connecting each other to the distal aorta, and the fact that we administered prostaglandin so early, there could have been a much worse outcome, because the delay in diagnosis was nearly 36 hours by the end of the first echo, which was day of life 1, if not day of life, halfway through this first day of life. And that was just a benefit, that we were very lucky that there was no negative impact, and that on outpatient visits, the physical exam, JH looked very happy, very healthy, and was a very cute baby. And then now we're wondering, beyond just the hypercoagulability state of COVID-19, is there an aspect of COVID-19 that could show an asymptomatic presentation in a mom who went through a normal prenatal course? And then we're talking about things like, is it a possible torch infection? Is it a possible transplacental or vertical transmission disease? As well as that, I think it's basically a call for extended research and a longitudinal study on neonates such as JH on the effect of, maternal neonatal COVID transmission. And just, the fact that we need to monitor these sort of patients for longer outcomes, more than just a few weeks or a few months, because it's an ever evolving disease. And that brings us to the end of the talk. On the last page, you'll see our conclusions as well as our references on the following slide. And we would like to give an acknowledgement to Dr. Graham at St. Luke's East for his help and guidance. Thank you.
Okay.
Thank you.
I see Dr. Johnson has his hand up. Dr. Johnson, go ahead.
Gentlemen, I won't point out to either of you students, but I'll ask a couple questions, and I need to start this out by making a couple comments. Well, as third-year medical students, our level of presentation is excellent. And I say that based upon, not only did you benefit from this experience with the patient, but you have grasped a whole lot of knowledge about the physiology, the science, and applied this in a clinical setting. So, applaud you. You're talking at the level of not a third-year medical student, you're talking at intern resident level that your attending physicians are going to identify with. So you are both to be congratulated on how well you have presented a case. It's a complex case, and I will go back because I might have missed a couple things in your initial presentation, but and I don't care, either one of you can answer the questions for me as I go through my series of questions. You may have said this, but was mother checked for lupus?
I believe that the mother, the tests performed, let me scroll back here, for anticardiolipin were performed both on mom and the infant. So all of these tests were performed, I think, both on mom and the infant.
I understand. I got the anticardiolipin. I'm just wondering about lupus anticoagulant, whether or not that was assayed. That's pretty typical and unexplainable reasons for clotting, but I just wondered if she was trained for that. The other thing is that the APGAR at birth, that was high. What was it, 8, 9, 10, something?
Yes.
Okay.
Yeah, they're very high.
Okay, did it ever go down? Did it ever?
We don't have that. So we only have the first 2 APGAR scores in 1 and 5 minutes. I don't know if they continued recording the APGAR scores past that time, but the documentation that we got did not specify. You know, it was difficult to obtain all the information since the baby was born at St. Luke's East, but most of our documentation came from Children's Mercy. So I'm not sure if they collected that.
Okay,
good
fair
question.
enough. Then the other thing is, I trust that all of these echo that were done were transthoracic echoes and not transesophageal. Were they
I can check that for you, but I think you're right. Yes, they were transthoracic. Yes.
I don't even know if they make a transesophageal echo for an infant. I don't know that answer.
Yeah.
Well, okay, so they're transthoracic echoes. Then with resolution of did peripheral femoral pulses improve?
I believe so, yes. Because when we definitely when we saw him in the clinic, femoral pulses was both something I and Dr. Graham were checking, and his femoral pulses, I believe, were improved as soon before he was released from the hospital. Yes,
absolutely.
And then,
so if you were the attending physician at the time without the benefit of a CT or a transesophageal echo, and you found decreased peripheral pulses in the leg, I think it's reasonable to make that assumption that you could have had a coarctation. The baby was born with a coarc. The fact that this had a series of 5 or more echoes later after aggressive treatment for unexplained thrombus certainly made sense that you were probably dealing with some manifestation of, again, unexplainable thrombus formation. To imply that it's related to the infection from COVID, I sure wish we had conclusive evidence. What marker would you think would help the most to say, yep, that's what caused this to begin with?
So I would guess, so I would say that due to the fact that it's we're seeing symptoms of viral myocarditis and high ESR and inflammation, I would look for inflammatory markers to confirm that The pathology was due to like hyperplasia of the aortic enema.
Okay, I got you. Well, again, fascinating case. You guys presented this in a very smooth, sequential manner, and both of you to be applauded. Thank you.
Thank you, Dr.
Thank you so much.
Dr. Schneider, go ahead.
First of all, I would like to congratulate you. Presented excellent. For me, it was like rounds, grand rounds, and so I commend you on doing this. So I also would like to make a suggestion. I don't know how much you are part of that research, but go to your preceptor or the people who you were working, physicians, and ask a possibility whether you can prepare a publication as a case report. I highly recommend you. So promise that your preceptors or who you work with, that their involvement will be at the level of providing with the guidance. So they will be definitely senior authors on that. So you will do all writing, and I'm confident that you can prepare it in very smooth and very logical way. So it doesn't require your very long work. It could be 3-4 pages enough. So after that, when you start, because you both of them there. So who will be the first author? Usually what I did in the lab, you have a head, you put 2 papers, folded papers there, and you pull who will be the first author, who will be the second author. That's honest, right? So, because believe me, that's sometimes happen, but I highly recommend you to make and prepare a case report. When you publish that case report for some highly competitive residency, when you met a permissive factor, which I call your board percentile. If you're high enough, everything is open for you, right? And in those highly competitive residency, a publication during, your being in medical school, it's a high commodity. So just don't drop this opportunity. It may not happen to you again. Explore a possibility of publishing. Thank you one more time. Thank you. This is the first, this is the class which is school stopped doing grounds. That is what, you never seen it, but that is a kind of, for Mike, we need to consider it because students themselves come to the point of these grounds. They are needed. Maybe now it's an example how it could be done remotely using Zoom, etc. But that will be kind of, we need to revive that approach which teaches students to report medical cases. So great, guys. I'm very pleased that you were not trained to do it, but your first experience, it's amazing.
Thank you,
Dr. Schneider. I think we were looking into publishing, something like this with our attending. He wasn't really, I don't think, interested in. But as you said, if Theja and I were to pick up most of the work, there is also a group of residents, I believe, at Children's Mercy that are publishing this case together with the other case that presented in earlier this year. I believe they're publishing at the British Journal of Medicine or a similar paper. And we really, Theja and I were discussing how we should go about contacting them, but we haven't figured that out yet. Maybe Dr. Newman would be a point of contact that has colleagues at Children's Mercy that can help us out with that.
Okay, thank you so much. Dr. Wolf, you have your hand up. Go ahead.
Yeah, I was going to echo some of the earlier accolades that you guys have received, but I was also going to point out that now you can be co-authors on publications. So, there's an asterisk after the second name, and so it's not quite as big of a deal to some extent as it used to be. The questions that I had were related to what you thought in terms of timing. I mean, I'd be interested in knowing if the mother had COVID antibodies. And the other question I'd be interested in knowing was, it seems to me rather unlikely that this happened after birth. I would consider that this was probably going on at the time of birth. And so if that's the case, I'm because it seems to me that had that happened acutely, I mean, you might have had the ductus arteriosus already closed, but you had processes in place that maintain that fetal vasculature long enough that the baby didn't die despite having that happen. So I was interested in your thoughts along those lines.
Yeah, I personally do believe that it wasn't necessarily an acute event. It must have developed during the latter trimesters of pregnancy. I don't have the maternal prenatal course, other than the fact that it was deemed normal by the OB. But I would not assume that this is. I would assume that this is a prolonged course rather than an acute event that occurred during birth.
And this was a suspicion of our attending physician, Dr. Graham. Wondered if mother had the antibodies. She did test negative a week prior to delivery, but that doesn't. PCR DNA test, only excludes current disease, meaning that she at the time of delivery was not infectious, but that doesn't exclude the possibility that she had COVID-19 sometimes during the pregnancy over the past 6 months. So that's definitely a good question. It's something to be looked into, and even future, because if those antibodies crossed over, they were more likely to cross over in the IgG phase, because IgM antibodies during the acute infection do not cross. But if she had the infection a month or so before the delivery, and in that last month of pregnancy, once she developed immunity to it, and IgG antibodies crossed over, and they definitely could have caused this, depending on the surface antigens on the patient's platelets or red blood cells.
So I'll make a comment here, and that is, in science and in biochemistry, PCR antibody testing, you can really never interpret a negative result, especially with antibody testing being so all over the map these days. It's just a comment. I'd like to.
Well, can I just? Oh,
go ahead.
Go ahead, Jeff. Finish your thought, and then I was going to follow up too quick.
Go ahead. I was going to segue into something else. Go ahead, Dr. Wolf.
Oh, okay. Well, I was going to say, I mean, the other thing is, does the baby have antibodies? Would be an interesting thing. But you're talking about the cardiomyocytes and stuff, and so there is that the Big Ten guys were concerned because they had a number of football players. I thought the stats were like around 1/3 of Big Ten football players that had tested positive for COVID had prolonged cardiomyocytes afterwards. And so it struck me that might have also somehow played a role here.
Okay, thank you, Dr. Wolf. Dr. Talley, you had your hand up. Are you still wanting to ask a question? I see you're still in the room.
Yeah, it's not so much a question as it is a response to Dr. Schneider's comment about working on research and getting publications and stuff. Actually, Theja is going to be our first victim in a site that has been developed in a clinical rotation, specifically having research as part of its activities within that rotation. And so we have our eye on Theja and hopefully many other students. But Dr. Williams has been working on that. So it's going to be more likely to be available.
Dr. Schneider, your hand is up next, and then Dr. Johnson.
I would like just suggest for you, so if you have access to the blood samples from the child, all right, so a mother, there are a lot of commercially available tests, ELISA tests for antibodies. You can contact even Dr. Stadler, his lab, where you can run simple ELISA under control of other people and provide a definite answer whether antibodies are found or not. So as you know that even mother had this infection, so viral infection is not imposed on the fetus, because how many cases we have a delivery of healthy baby from mother with HIV infection. So that is, placenta normally is not allowed penetration, but if you find in the baby's blood IgG antibodies, that will be indication that he or she, that's so the baby was fetus was exposed while in the uterus. So that is what they think you may add, and that's data may be available and make you a co-author on that publication. All right.
Yes.
Dr. Johnson.
Gentlemen, just a curiosity. If you're thinking of anything relevant to myocarditis, I have a question for you guys. Did you have the benefit or to review and whether or not an electrocardiogram was ever done on this baby?
I personally did not see an EKG done.
No, it wasn't in the. I have his hospital course here in front of me, and EKG was not performed. No.
Okay. Well, in the event that myocarditis diagnosis, then as you know, you would see some T-wave changes secondary to myocarditis in an adult and in an adolescent. I don't have a clue what it would look like in a baby like this, but I just wondered if an EKG was ever done. Thank you.
Okay, any more questions for our speakers? I'd like to, Mike, your hand is up. Okay. I'd like to make a comment. I've been working with these two student doctors over the last day or two to coach them on just certain aesthetics of the slide presentation. And what I'll note is these two are eminently coachable, and coachability in the business you're about to launch into, being a medical physician, is paramount. So that you took your presentation from where it was to where it is today in such a short time speaks volumes about you two. So congratulations. You listened and put into practice what we talked about. Thank you. Thank you for your presentation. Please go out and spread the word to your colleagues about this opportunity. It's a great learning opportunity and publication opportunities too. Appreciate Kansas City students becoming involved, and the more the merrier. Appreciate that a lot. Dr. Creamer, did you have something you'd like to add?
I was just giving thumbs up.
I presume that means you concur with my opinion.
Yes. Yeah, I thought they did a great.
Fantastic job. And again, it went from 0 to 100 miles an hour in like a day. So great job, you two. All right, everybody on Vail, and let's thank our speakers. Take care, you guys.
Thank you so much. It was a privilege.
Everybody have a great weekend.
Yes, sir.